Welcome to Genomics Gupshup. Genomics Gupshup is an initiative by MapmyGenome to create a community around genomics and to simplify genomics for everyone. And we do this by bringing together experts from allied areas like medicine, genetic counseling, nutrition, fitness, and more. Please join us as we spread the word about this exciting science of genomics. We are now available on your favorite podcast as well. Just search for Genomics Gupshup on Apple Podcasts, Spotify, Amazon, or Google Podcast. Today in our 39th episode, we have Dr. Soumya, who is a surgical oncologist and has more than 10 years of experience with a special interest in breast oncoplasty, gastrointestinal oncology, endocrine, and gynec oncology. She even has a hospital named after her and works over there. That's Dr. Soumya's hospital. She's graduated from, she has an MBBS degree from Osmania and has done many other things, which I will let her explain as we go along in this conversation. So Dr. Soumya, thank you so much for joining us today on Genomics Gupshup. We really appreciate the time that you gave us today.
Thank you for having me.
So Dr. Soumya, can we start with what sparked your curiosity in surgical oncology, especially specializing in breast oncoplasty?
So my interest in surgery had started off in my internship days. So we intern in all the departments, and I found surgery to be the most interesting.
Mm-hmm.
And then I went on to watch my dad. I observed under my dad and then a plastic surgeon as well. And I've gone to CT surgery, all the rotations, and I found surgical oncology the most interesting. So then I decided to take up general surgery. And you're exposed to a lot more subspecialties and super specialties when you do your general surgery. And even then, I found surgical oncology to be the most interesting. And that's when I made up my mind.
Mm-hmm.
So from the time I joined my MBBS, I was sure I wanted to be a surgeon. And as I just kept getting exposed more and more to surgery, my love for it just increased. And that's when I took up surgical oncology. Why breast? Then I wanted to do breast oncoplasty because now it's the most common cancer among women in India. It's breast cancer. Previously, it used to be cervix. When we treat a cancer, other than just the oncology part of it, there are a lot of psychological issues that people have, social, emotional issues. And all I used to think, probably it's more easier for a woman to go, let out whatever she had to say to another lady. There were very few men there were very few women in the field back then. Most of the men were surgical oncologists. Most of the surgical oncologists were men and very few women were there. So I thought it would be really nice, to go see a lady for a breast cancer or say a cervical cancer, get all your gynec examinations done. They're at a greater comfort. And probably, not just disease related, that there are a lot of other issues when you treat oncology. It's not just the disease as such. So it's an entire circle wherein you should issues probably that not everyone is comfortable addressing. Then there is sexual issues, psychosocial issues. So, then it increased. That continued to make me pursue breast oncoplasty as well. And then breast oncoplasty is something wherein there is an oncology part of it, and then there's a plastic aesthetic part to it. That definitely has a lot of impact on how they perform, how their life is after getting treated.
So that's what is oncoplasty, like you're basically plastic surgery combined
with oncology. Yes.
Sorry, you were saying something.
Yeah, so it's basically oncology and plastic surgery.
Okay. And I think that's very important because in the end, I think your confidence, how you live your life and all.
How you look, it definitely matters because when, breast cancers of different types. And so if they have the most favorable dominant, they survive for long. So when the survival is long, so you look at the other aspects as well. Not only in terms of, how many years, and it's also the quality of life.
Absolutely.
Quality of life matters.
So a lot of people think that, once they don't want to go to a doctor and find out that they have cancer, right? or even like one of the things that we see in, we have, products like Oncomap and others, where we are telling people we'll help you understand your risk for a particular disease. But people are, for some reason, I think they're okay with every other disease and they're, scared. But breast cancer has a great, survival rate, right? I mean, in terms of what has happened. Where does this fear for people come from in finding out that they have a risk for breast cancer?
It's been an old age thought that, from years it's been, once you have cancer, you're not going to make it, or there are high chances of, not recovering, and you might succumb to the disease. So that thought is still there. And there are still many people who don't come because the lump is painless. It could be just nothing. They don't want to hear the diagnosis of a cancer. Probably they think because you're not going to make it. It's incurable, is what majority of the population thinks. Not just with breast, with most of the things.
But with breast, I think, what are the statistics from like if it came early?
There's also a lot of stigma to go get a breast examined, and there even though there are a lot of breast awareness campaigns going on, people still don't go. If there's a lump detected like 6 months ago, they tend to this is painless, nothing much, nothing to worry. So we still see, not only from rural areas but even in cities, we've seen people come after 6-7 months, wherein the skin is involved, and you could have seen the growth ulcerated out, and it's paining or bleeding, and lumps in the axilla, or which things could have changed if they were treated much earlier, because a breast cancer treated at stage 1 has a much greater 5 or 10-year survival rate compared to something that is treated in the third. You are getting down your chances of survival. And if you think in terms of somebody who has, obviously a patient who has to spend in money, as your stage progresses, the money you spend on your treatment also would increase, because you would need a multimodality treatment. Multimodality treatment, if you're coming with a locally advanced, you might need additional radiation, which you might not need if it's a first, early stage, or you might not need adjuvant chemo if you come with a very early cancer, which you will definitely need if it's a locally advanced. Everything increases.
So people don't want to see.
Your chances of getting away with a breast conservation would not be there if it's a very locally advanced cancer.
I think that's the message you want to tell people, that it is not like it's like the end of life, right? I mean, if you go early to your doctor, or understand that there is a family history, there's a risk, the chances of you recovering from that are way higher than if you went much later, right? At some point you will go, but you'll be spending more and you'll be not having the same quality of life.
Yeah, exactly.
But I guess, that is unfortunately, we need to keep working on it, and hopefully people will be educated.
There are a lot of issues when it comes to women. Not this, they don't want to go, they put themselves last on the list. Everything else comes first, and then they are the last priority. So probably we've seen women who wait till their son's wedding is over or the daughter's wedding is over, let things get settled at home, and then we'll go consult. Then we'll get our surgery done. Probably when it's convenient for everybody in the holidays. Let's wait for 2-3 months. Anyways, the holidays are due. Let's go. So multiple scenarios.
So yeah.
Some are because they don't have knowledge, not aware, don't have enough awareness. Some are because
they're not prioritizing. Yeah. So you think it's also, you mentioned something that one of the reasons why you wanted to become a breast cancer surgeon was that there are very few women in this field. Do you think that is changing now? You think that
a lot of women now, even if you take up general surgery as such, so you usually do after MBBS, we need to do a post graduation, which is general surgery, and then you do your surgical oncology, and then if you want, you specialize in breast. You're trained in breast, even in surgical onco. But yeah, so we see a lot of women taking up general surgery now. So the number of students, there are a lot more girls compared to boys nowadays.
So I think that's good. Maybe that some of those challenges of
used to be very few previously.
And do you think, like, one of the first things that when people think about genetics and genomics, I think the one person that comes to everybody's mind is Angelina Jolie, right? Because she created the whole thing where she did a double mastectomy after finding out the BRCA variant. Do you also get that question quite a lot in terms of when patients first come to you? We've had some people who came to me and said, I want to do what Angelina Jolie did, right? But is that something that you also encounter quite frequently when you talk to them?
Genetic testing has been around for a while. In 2010 or 11, 12, very few centers used to do it. In the late 2000s, very few centers used to do, and it was quite expensive. It was not that widely available. But then later, this prophylactic mastectomy is what was made popular by Angelina Jolie. Genetic testing was definitely there. I mean, obviously, whatever a celebrity does becomes famous. Becomes more known overnight.
Okay.
There are few who ask about prophylactic bilateral mastectomy. According to me, it's a very you need to be really strong to make that decision. Emotionally, a woman is definitely affected a lot with a bilateral mastectomy. It's not that easy to take in, and it's not that you're taking away 100% risk. You do a skin sparing mastectomy. It's not that you can give her 100% guarantee that she would never get it. So that the patient should be first educated about that, and they should also be told that there are other options.
Correct.
Like chemo prevention, surveillance. You just keep getting screened routinely. That is not the only thing. But then if they are strong enough and they want to undergo, yes, fine. And they should also be explained that BRCA is not just about breast cancer. So there is a list of diseases that they can have. They could have breast, ovary, pancreas. So they should be informed about all that.
Yes.
So in the most common ones are addressed. So breast and ovary are the most common in BRCA. So prophylactic salping or oophorectomy, that is both the ovaries being removed, and bilateral mastectomies. Yes, we've had quite a few patients undergoing prophylactic salping oophorectomy though, because that's more difficult to screen. Ovaries are more difficult to screen than the breast. Because serum CA125 is not that specific to ovary, and all the tumors need not be CA125 producing.
And I think that is the thing. I mean,
there are very few here who come for prophylactic mastectomy. It's more common in the West.
True, and that's what I tell people, that it is not about going and getting a surgery done the moment you find out you have a mutation, right?
Yeah.
And I say that's ultimately
there are options.
Yeah. There are many options, and most of the time your doctor is probably not going to recommend that to you on your first instance, saying that you found a mutation, you need to do surgery, right? I think that's something that I tell that people have to understand that for Angelina Jolie, there are a range of other things that made them make that decision, and it's usually not common.
Someone has BRCA, is BRCA 1 or 2 positive. It doesn't mean they're going to 100% get it.
Yes, exactly.
So if it's something like FAP, there's a 100% chance that by 50 or whatever age they're going to get it when they have multiple polyps.
Right.
Doing something like this, doing colectomies in them, proctocolectomies and ileoanal anastomosis in them would make sense. But here, I think it's but each one to their own. It's ultimately the patient's wish. And they should also understand the psychological impact it's going to have later on them.
True. And ultimately, it's a decision between a patient and the doctor, and what happens out of that, right? But people should also understand that BRCA is not the only mutation that can cause breast cancer. There are other mutations.
A lot of other mutations.
But I think we also see occasionally, I think you meet people and they'll tell me that I did a BRCA test. So I said, was there a specific reason you did that, or was there something that you were looking? They said, no, I just wanted to do it because I said I wanted to make sure that I reduce my chance of breast cancer. I said, well, there are also other genes that are there. Maybe you need to look at other things as well. But I think right now, for good or bad, I think Angelina Jolie created awareness, but I think we need to.
Angelina Jolie had a reason. Her mother was BRCA positive.
Exactly.
That's the reason.
Yeah. which people don't understand, right? Like they think that that becomes the standard test for only test that you can do.
So you should be in the risk assessment.
Exactly.
For the risk assessment model, and then if you're a high risk, then get tested. There are recommendations for genetic testing.
Right.
So we should probably abide by that and then go.
Right. So you feel that we've been discussing that one, I think the number of people who would come voluntarily for some sort of a prophylactic surgery are less, but the people who come in, and you also mentioned that there's a lot of psychological and other things that they need to be concerned about. Do you think that there are more things that people should be aware of when they want to come visit a doctor? Should they be more, when should they first come to you? And do you think that there are things that maybe a general population should know before they actually even are visiting doctors, because they are just, let's assume that the fear of cancer is not there, or that they want to know, because there is a segment of people who want to understand. So what would you tell them when it comes to knowing a little bit more?
So we should know when to visit. What are the warning signs? So we have something called warning signs. So, a mole which is increasing in size, or something that's itchy, something which has become asymmetric, that's not normal. A mole which has been there for long. A lump anywhere which is increasing in size. And then blood from any of the orifices, if it's either your nose or your tongue or your anal orifice, or abnormal menstrual bleeding also is not normal. So postmenopausal bleeding, intermenstrual bleeding, all these are not normal. Then loss of appetite, loss of weight, unexplained, unattributable loss of, not that, your appetite is just lost and you're losing weight, and persistent cough, unrelenting cough for a long time. All these are supposed to be, and ulcers, non-healing wounds anywhere. The ones that don't heal for 4 to 6 weeks or beyond. All these are warning signs. So these are something that need to be addressed. You can go meet a primary physician or a surgeon, general surgeon, and these are to be evaluated. Lumps, ulcers, bleeding, loss of weight, appetite, unexplained cough. All these must be evaluated.
So these would be like a checklist.
Warning signs.
So, we've been talking about mostly breast cancer for women, but there are also some men who can get breast cancer.
Many are not aware that men can get breast cancer, yes.
And so what happens in the case of so for women, let's assume that, there are many options that you give, surveillance and other things. And then, of course, the more aggressive options like your prophylactic mastectomy and others. What happens to males? Is that a similar sort of set of guidelines that happen, or
is a set of guidelines, because even in men they have estrogen receptors and progesterone. The similar set of guidelines, and it's more easy to screen in them.
Okay, and why is it easier to screen in them? Is there something that
for them to notice it, because women tend to. For them, self-examination is much easier. To say, not that screening as such, but it's easier to self-examine in them. And male breast cancer in a family should always be, seen with suspicion. Definite genetic testing has to be done. So we have some criteria for each cancer. When do you send them for genetic testing?
Mm-hmm.
So if it's a breast, so any triple negative. So we basically classify breast cancers into 4 types based on their, molecular profiling.
Mm-hmm.
So any triple negative less than 60. And also the number of relatives in their house who are having breast cancer. So we take 1st-degree relatives, 2nd-degree relatives. So based on it's like 3 or more or 2 or more. And if in the same family there's 1 breast and ovary, or if there's a male breast cancer, we send them all for genetic testing. Or if the age of the patient at detection is young, we send them. Even for ovarian cancers, it's a similar thing. And in colon cancers, if they're having multiple polyps. So family history is pretty important. The only, 10% of most cancers are genetic.
Correct. Yeah.
85 to 90 are sporadic. Most of them think that, in general population, the thought is around 90% are genetic, only 10 come without reason, but it's actually the other way around.
Correct. I think we've been saying that, and I think that's what I tell people, that it's not just about understanding that you have a genetic risk, because that's a small percentage of risk. Your risk can come from things like lifestyle, right? Like your smoking.
Common cause.
Yes.
1/3 of all the cancers are because of preventable causes like smoking.
Correct. And that's what we tell people, that, the whole purpose is
Very
that.
high. That means it's 30%.
Correct. Actually, one study where I read showed almost up to 50% are preventable. I guess they took an overall aggregate level of the same. But in the case of breast cancer, when it comes to lifestyle changes, are there any specific guidelines that are there for people that they can do something, to be able to prevent that, rather than, let's say they don't come get a genetic test, they don't come visit you, so they're not coming to either you or me, but I mean, can we make them more aware that, what changes can they make?
So we need to have an understanding. So what are the causes for breast cancer? If we keep aside the 10% genetic, which we can do nothing about, so there are dietary factors. So high fat, then, alcohol consumption, smoking in women, and then nulliparity is, is an established cause of breast cancers, not having children. And then age at first childbirth, about 35 years of age. That also is an established factor. And then there's, early menarche, late menopause. This is nothing that we can do about. There's nothing that we can do about it. So you're exposed to hormones for a longer period of time in your life. And then, like I said, I think I spoke about obesity as well. Lack of physical activity. Obesity, lack of physical activity, we can do something about it. And then hormone replacement therapy in menopause for a prolonged period. So higher levels of estrogen. And we especially advise people not to gain weight once they attain menopause. So these are the factors. And then there are a few, things like predisposition to radiation in their teens or, below 30 years of age. These are the risk factors that we know. We put these people under a little higher surveillance, the ones that have received radiation, or previously people who had biopsies which had some atypical hyperplasias and all. So what we could advise is regular exercise, at least 30 minutes a day for 5 days a week, that everyone knows. High fiber, low fat diet. Include a lot of fruits and vegetables in your diet. Okay, avoid smoking. Smoking causes not just breast cancer, but from your mouth to the urethra, it can cause like a varied number. It can cause esophagus, stomach, bladder, kidney, and whatnot, or lung, oral cavity, all these. Same thing with it has an additive effect. Alcohol has an additive effect with
Smoking.
smoking. And avoid red meat.
So there are lots of guidelines. Hopefully people will, that's one of the things we hope also people can understand, that, there are actual real changes that you can do that will reduce your chances.
It is actually westernizing.
Yeah.
If you take our previous generations, they had a lot of fruits and veggies. They hardly ate out. Bread, cheese, and all was not part of our culture. And what we usually ate was home cooked or locally available. We never ate too much of canned food or, frozen food and stuff like that.
So I guess this is a challenge of globalization and availability of too easy availability.
Yeah. And stress management is another thing.
Yeah. I guess stress is a big thing, especially now post-COVID. I think we're seeing so many more, challenges when it comes to mental health, because people don't have a real connection with other people and so on. But there's one more question I wanted to ask you, which was that, you mentioned smoking is a big problem, almost, I think 30% or more, you said, or, it has a big
30%
effect.
of the cancers, yeah.
So what do people do if, let's say, you're living in, where other people are smoking? You might not be smoking. Is secondary smoke also something as dangerous? And should you tell people who are smoking around you not to smoke around you? Is that something?
You should. See, our patients, we make it a point. We tell them they have to quit smoking at least 4 weeks prior to their surgery. Because it's not just in terms of disease, their outcomes after surgery. I mean, their lungs are affected, right? So they're at higher risk. And morbidity is increased because of smoking. If you want to do plastic surgery, you cannot do on a current smoker. There won't be good results after that. So they have multiple issues. And if they continue to smoke, there is no point in treating, because it's like field cancerization. When in a smoker, suppose the tongue has been affected and you removed part of the tongue. But if he continues to smoke, his throat is exposed, his buccal cavity is exposed. I mean, his buccal mucosa is exposed, his alveolus is exposed, his lung is exposed. What is the point? There's no point. He's going to come back with something again.
Yeah.
So smoking cessation is very, very important in treating these patients. Counseling, then, treatment. You can give them nicotine patches. Basically, the person should be very motivated.
So recently, I think I was visiting Asha Hospital. I was giving a talk, and it was quite interesting. They had some smoking de-addiction, interesting equipment. Yeah, which was more like you're using magnetic resonance to sort of help people with de-addiction, right? And I think maybe people need to look at options to be able to do that, because many people that smoke, and when they talk to me, they say, yeah, we know it is bad, we don't know how to what to do about it, right? We're trying, but you're not able to do.
These nicotine patches, gums, sprays have been available for a while now.
Yeah, I think it's more that people should want to do it first.
Motivation on the side of the patient matters the most.
Yeah. And also, I think because there are genetically also, some of them might be at, they might be at a point where, because they are predisposed to actually having more dependence, because it takes longer to be able to get there. So I think one of the things we tell people is that maybe if you had the risk, but you never smoked, you're perfectly fine, right? Like you never even picked a cigarette, you'll probably not have dependence on it. But if you did, then maybe you need to try a little bit harder from using all these other aids that you can get, whether it's patches or other things. But I was quite fascinated by this new piece of equipment that I saw, which allows you to sort of train your brain in some ways to not get it. I don't know the long-term usage of it, but it looked pretty nice, that I thought maybe at some point will become more commonplace.
And it's become very common, actually. If you would say probably 15 years earlier, we had very few women smokers. It's very common in Europe. It's equal among men and women. In India, it was a very rare thing, but now it's become common among women as well.
True. I think it's more that I think socially, when we create these personas of people who are cool, who are smoking or drinking, I think
There's nothing cool about it.
Exactly. I think, even with the big labels that are there, people...
This is not the equality that you want.
Exactly. I agree. I think we want equality in pay, we want equality in, being able to work as...
are good at multitasking. Anyways, we have women, so probably we would say that they're the smarter beings, but still, this is not what you should be comparing yourself with. Okay.
But I think it's probably more, we need to change from a societal basis.
Compared to the West, we get breast cancers 10 years earlier. And HER2 positivity is a little higher among us compared to the West. So we need to understand. So whatever applies to the West need not apply to us, the Asian population or the Indian population. We are a different genetic makeup. They are a different genetic makeup. And most of the studies that are published mostly comes from the larger represented population is them, the Western population. So we should be aware of these already genetically inherent risks that we have because of our race. We're anyways getting it 10 years earlier. We are predisposed a little more to HER2 positive cancers compared to them. So we don't have to ape the nonsense that they are doing from there.
Maybe you can help people understand what is HER2 positive and what is triple negative breast cancer also, because I think that incidence is also higher in India, and maybe how that affects the treatment for a lot of people as well, right?
So based on molecular profiling, we have 4 types of cancer. What exactly do we take into consideration to classify them into these 4 types is ER, that's the estrogen receptor, progesterone receptor, HER2, and Ki67. So we ask for these even before we begin our treatment. So once the core biopsy comes as IDCC, that is a breast cancer, then we ask for these 4 because that helps us to classify it and prognosticate it and help us take treatment decisions as well. It's very necessary to do this much before we initiate any kind of treatment. So we have luminal A, which is considered the best type, which is high on ER/PR positivity, and Ki67 is low. Ki67 is a proliferative index. So that is low in luminal A, which is considered to be the most best prognostic category. Then comes luminal B, wherein ER/PR are strong positive, but Ki67 is a little higher compared to the luminal A. Then we have HER2 positive, wherein it is HER2 enriched types. And then we have the triple negative, wherein it's ER negative, PR negative, and HER2 negative. So HER2 positive and triple negative are not so good compared to the luminal A and B category. So how would it change our treatment strategies? If it's HER2 positive, we would like to give Herceptin. So it's a monoclonal antibody prior to doing surgery. Even in triple negative, we want to give chemotherapy prior to surgery. So why do you want to give? So these are the poorer prognostic categories, these two. So the multiple advantages of giving, multiple reasons for giving neoadjuvant chemotherapy, that is chemotherapy before surgery. See, we consider it to be a systemic disease from the start. You cannot see the cells. A PET scan wouldn't be able to catch your other cells in circulation. So you're targeting that. And for people who want breast conservation, you're downsizing the tumor. And the other thing with the triple negative cancers is the one you prognosticated even based on the response after chemotherapy. So once all your chemo is done, you've undergone surgery, and there is no viable tumor, you come under a better prognostic group. And if there is any viable tumor, there is further treatment that should be given to you. So this we would know. We give them capecitabine. So once there's a viable tumor, this we know only if we give neoadjuvant chemotherapy. So they said that there would not be an overall survival benefit. There's no that is what was thought. But now there are studies which are saying that there's also they say that there was only a disease-free survival, DFS benefit. But now there are few studies which say there's an OS benefit as well in these categories. So it's very important to prognosticate them and to decide what chemotherapy you want to give, anthracycline-based chemotherapy, Herceptin, or whom we want to give.
So if I had to simplify this, if in these four categories, Indians are getting a higher risk of HER2
even in us, hormone positive is the most common, but compared to the West, if you take, if compared to their numbers, our triple negativity and HER2 positive are a little higher compared to them.
And therefore, we need to be a little bit more careful about all our other lifestyle things, which will basically push it further ahead. So we need to make sure that people understand that, molecular profiling helps the doctors in understanding where, what kind of treatment options
and what treatment options we have.
But I think there are many things that patients can do on their own, which right now they're doing mostly to spoil that chances of getting better, right? So I think people, for instance, by smoking, you're increasing your odds of getting these diseases or drinking or other things.
And even not just a risk of diseases, even your recovery, your wound healing is poor when you smoke. The adverse effects that you have with anesthesia are higher because your lungs are affected. And then your cardiovascular health also is not good because smoking affects your vessels, affects everything.
So it has a systemic effect, basically.
Exactly. Not just related to oncology, but other systems as well.
I think
bear the brunt.
Yeah. So it's not just your oncology or your cancer risk, but I think there are so many other risks that Dr. Soumya just so nicely explained to all of us about. So do you think that, when we look at, you mentioned early on in this conversation that there's a lot of social, psychological and other challenges that you undergo when as a doctor. But do you think that there is a role that genetic counseling plays in this whole realm? Because you have to profile these customers, you have to understand how to treat them. But do you think that genetic counselors have a role to play in this, in this field, or do you think that we'll reach a point where the medical oncologists and the surgical oncologists can themselves do that role of a genetic counselor as well?
See, we are equipped to do a certain amount of genetic counseling, but a genetic counselor is definitely a must. So first, our job is to identify who needs to be genetically tested.
Mm.
So there are few red flags in the profile that alert us to probably this patient could be a hereditary breast cancer syndrome patient. So when we look at any patient, we ask them their family history. Their age is obviously the first risk factor, at what age they've been diagnosed. Then their parity, how many kids they've had, at what age they've had. Are they, first of all, do they have any children? Then their family history of not just breast cancer, but ovarian. There are a lot of syndromes which can be associated with this, male breast cancer, pancreatic cancers, and all that. So when we see such things, we refer them for genetic testing or to a counselor. So just because I referred someone for genetic testing, it doesn't mean that they need to get tested. So a counselor's job would mainly be to tell them what is genetic testing, what are the pros of getting it done, what are the cons of getting it done. So if they refuse to get genetic testing done, what are they to lose? And if they decide to get genetic testing done, how is the outcome going to help them? What are the options they have? Whether be it surveillance or treatment. Is the treatment going to change just because they are positive for a certain mutation? Is it any different from the general population? And what exactly would they do with the relatives as well? That also is part of, suppose if the mother had breast cancer, what is going to happen with the children, with the daughters, her sister? All those need to be explained. And then the patient takes an informed decision, instead of blindly just going and getting the test done. And
Absolutely. So are there any specific markers? I think we spoke a lot about BRCA1 and 2. But are there other mutations that you are normally...
mutations, P53 mutations, PALP mutations, all these. Then again, there are multiple things when we ask for a lot of these. So most common ones, so BRCA1 and 2 have around 1,000 mutations which are there, which are known mutations. And then there are, somebody has a strong family history, but if BRCA1 and 2 are negative, and there are, a lot of first and second degree relatives, it doesn't mean that you rule out genetic history. Hereditary cancers, you're supposed to check for other mutations as well in those people. So we usually tend to ask for additional mutation testing when these two are negative, when it's strongly suggestive that there could be a mutant gene in the family.
So can I move to a slightly different area? And I think, we recently launched a gut microbiome test, and it looks like, now everything is correlating it back to the gut microbiome. Do you think that, especially when you're looking at gastrointestinal cancers and others, do you think that that is something that would help in early detection and intervention in gastro cancers?
See, actually, our gut microbiome affects everything from our mental health. So obesity, mental health, and malignancies, it's all interlinked. There are studies which identified that, there are certain bacteria which are more common in people who are susceptible to colorectal cancers. And it's seen in red meat eaters and high fat, low fiber. Your high fiber diet is kind of responsible for, and fruit and veggies in your diet are responsible for the good bacteria in our colon. So the ones, the cancer causing ones obviously produce a lot more free radical damage, induce damage to our gut. So identifying these might help with colorectal cancer, but it's not a category 1 recommendation as of now, but probably in the future. It's not a mandatory recommendation as of now, but yeah, maybe in the future we'll get there. But there are definite studies which show that your gut microbiome is responsible for everything in your homeostasis.
Okay.
For your body to run in a well lubricated, mechanized way. Any derangement in that has psychological effects as well.
I have done that 4 or 5 times now.
Pardon?
I've done my test 4 or 5 times now.
Okay.
It's fascinating because you can start seeing the effects of what you're eating on the...
We are what we eat.
Yeah.
So
I think
lose kills a certain amount of good bacteria that we have. Then our food. So we have a lot of prebiotics that we have in our Indian food, like this jeera, curd, probiotics and prebiotics are, traditional Indian cooking.
So I think if you can avoid a lot of the things that, like the white
junk,
yeah,
red meat.
But it's a little hard, I think, when people are constantly exposed to it in
exactly, and it's easily available.
Yeah. So I think today
we are running around so much, it might not always be possible to stick to it.
Okay. So my daughters were in town, and so we're having lunch today. And in the lunch, I think one of the things he said, okay, fine, we can order a bowl of fruits. My daughter is off. She doesn't eat non-veg. She doesn't eat cheese. She doesn't eat. She's just given up recently a lot of stuff. And pretty much it looked like we had to, eliminate most of the food in some of these, in some of the restaurant related food, right? So I think that becomes a challenge. And I think when you go to a common place, people have to realize that, we have to be mindful of where you're going, because ultimately that will influence the decisions on what you eat. And that will ultimately show in your gut microbiome and the rest of your body. But
reset it would take a while.
Correct. Yeah. So I think we move to the the second part of this conversation. I know I can continue. I think you have such wonderful knowledge that we can continue, but we'll try to wrap it in about an hour. So I wanted to ask 2-3 common questions that I ask all my guests. The first one is, and I think we've kind of gone through this, but what is prevention according to you?
See, so I mean, prevention normally is of 3 types: primary, secondary, and tertiary prevention. So, primary comes in with your vaccines, secondary is with your screening, and tertiary is just you're treating it. According to me, prevention should start with your lifestyle changes, or probably the way you eat, what you do, and vaccines. And everybody should be aware of this HPV vaccine. It's 99.9% of the cervical cancers are because of human papillomavirus. It not only causes cervical cancers, but anal cancers, and as well as oral cavity cancers. So oral cavity cancers are also caused because of. So when you have a way of, there's a short way of preventing it. 99.9% of these cancers. So all women before their first intercourse should get HPV vaccines. So now the approved age is around 9 years. So 3 doses or 2 doses, that should help. And then HBsAg vaccines in the high risk group, like doctors, healthcare workers, or people who handle medical waste. All these people should have these vaccines. Lifestyle, food, exercise, and all are anyways there. And then screening. Screening is another thing. See, we don't have mandatory screening programs in our country because it's a lot of financial burden as of now. Most of the countries have a definite screening mammogram, pap smears a day. Pap smears and all are taken in these primary health centers and at the rural level, right? These ASHA workers, and so they have this. They mobilize them, and Government of India actually has a lot of programs to educate. Even this National Tobacco Control Program. So they put up shows, puppets, and they educate them. And you have these posters at their PHCs, rural health centers, to educate the local people to, avoid smoking, quit smoking. And women are taken up for pap smears. These healthcare workers are, taught about what are the red flags. Mobilize them, ask them to go see their health centers. Mm-hmm. There is a certain amount of effort from the government as well, but we should make an effort as well. Go get ourselves screened, get a mammogram done, not only when you have a relative who's at risk, but once you're 50, it should. Obviously, if we have a family history, then it's much earlier. We start off much earlier. But once we are 50, then get a screening mammogram. And in your 30s, get a pap first done once and then later on. Because screening tests, cannot be done for every cancer. The most common ones are screened. The organ to be screened should be, easily amenable for screening. So breast is a surface organ. It can be screened. Cervix as well, it can be screened. You can't screen the lungs, the stomach. Colon, again, screening is done in high-risk individuals. So population-based It's all the screening programs of each country are totally population based. So the most common cancers are screened. And even oral cavity cancer screening is taught at the primary healthcare center levels. Because I studied from this our regional cancer center at MNJ. So we had programs wherein doctors from the peripheries come and we teach them what exactly to look for. So what exactly to look for, what are the warning signs, and you refer them to us. So a lot of these healthcare workers are also taught screening for breast cancers, cervical cancers, oral cavity cancers, because you might not have, you can't have doctors even in the smallest of villages, every small village, right? They're there in the district level, and then there's in few villages, the smaller ones, these ASHA workers and, healthcare workers go and then educate them, screen them and all. Screening is very important. The primary and secondary should be our goal.
Yeah, absolutely. I think at least if we can get to certain levels of screening, people understand, I think we would have at least reduced quite a significant portion of the number.
All women should be taught self-breast examination from their teens because they need to know what a normal breast is. Only then would, examine and see.
I remember that, in the US, I remember going to someone's house and in their bathroom, that whole process of self-examination. So they had the chart over there. Right? So it was quite interesting to see that,
Because the right way of self-breast examination also is necessary.
So they had given all the steps like
the flat of the hands and not hold it like this.
Yeah. So it was the first time I saw that, and then I saw it in a few other places as well. But that was many years ago. I think almost 15 years ago that I remember that I saw some of these, what to do and where, and it was placed in people's houses. So maybe we need to do a bigger campaign around that as well.
Exactly, because see, that's actually it's free of cost.
Correct.
But you're not spending anything except a minute or two in the bathroom. That's it. So you need to know that how do you examine? You examine your breast, the nipple, the areola, the axilla, everything. And it should be taught young, so that they identify any small changes and what exactly is abnormal.
So, I'm sure that, like in other professions, there are many myths that are there around breast cancer. Can you talk a little bit about some of the myths that you normally see in your patients?
Not just breast cancer, but I mean, most cancer patients, the first question they ask us is, can my mom stay in my house? We have 2 young kids. They think it's a communicable disease.
Wow, I didn't know that. Okay, so the people think breast cancer is also communicable.
Yeah, not just breast cancer or any cancer. Somehow they feel it's a communicable disease, wherein it's not. And then during chemotherapy, is it okay? So we tell them, so you guys are not going to get affected by the patient, but you all might pose a threat to him or her because during chemotherapy, her immunity or his immunity is totally down. And if you guys have a cough and cold, you'll end up giving that infection to her, and she's the one who's going to suffer because she doesn't have the immunity to fight the infection. So there's no threat to you guys from her, but definitely from you to her. That's a myth that I've seen quite a lot, and we still see it. Is it okay there are young kids in the house? Can she handle them? And is it okay to live in the same place when she's having chemotherapy? We've seen that quite a lot.
Yeah, it's quite fascinating when I look at all the myths that are there around the medical profession, and what the average common person thinks about it is quite fascinating. But are there also like myths around treatment options that people have with?
Yeah, that a lot of people have, I don't know if it's a myth or what, but a lot of them fear that the hair loss with chemo is permanent, and that breast conservation is not an option. Or the myth that I've seen is that, people who conserve their breast tend to have a lower survival compared to those who have had a mastectomy. That is, the entire breast has been removed. This is one thing that I've seen. That's a fear probably, or they've heard it from somebody. Don't get breast conservation done. Just get the entire breast removed, because people who get breast conservation die faster compared to. But that's not the case. When the only thing is when breast conservation is done, the remaining breast should be irradiated. There is a slightly higher chance of local recurrence compared to mastectomy, but overall survival is the same in both. There are multiple factors that affect their overall survival. The biology of the tumor, the stage at which it was diagnosed, all these things matter, not just the kind of surgery that was done.
And what is healthy aging according to you?
Healthy aging, I feel, is a more of a mental thing. It's not just the physical aspect or the exterior aspect that we are supposed to, look at. We say it's not the physical age, it's the physiological age. A 60-year-old, two 60-year-olds are never the same. So one 60-year-old might be worse than a 70-year-old. So we look at the physiological age of a patient rather than of anybody, like when you're going to treat them, rather than the number. What can we do for, that we age well? Our food is what we eat, and probably exercise matters a lot. Being physically active, doing something that we like. It's difficult to not have to lead a totally stress-free life nowadays. So probably we should just find options wherein we balance it. Something you like. Everybody has a hobby, or everybody likes something other than the routine. So we should find a way to probably do that.
Right. I think
healthy thing is about and accept it. You can never be 20 always.
All right. So, but maybe we can be 25 always. No, but I think one thing is that we are coming up with the epigenetic test that sort of helps you understand the biological age as well. So we can have your calendar year as well as what you can see in terms of the biological
age. Yeah.
So now I think, you talked about, some of the hobbies and all of that that are there. So let me come to the last segment of our show, which is the rapid fire.
Okay.
So what is your hobby? Since you started with that question that everybody should have a hobby, maybe you would like to understand what your hobbies are.
Other than surgery, something that really fascinates me is traveling. I like to go to different places, see their culture, eat their food. I'm not much of a city person, but I'd like to see those quaint little towns and villages where, you're closest to nature. And I've always wanted to learn the piano.
Oh, that's nice. So you have
I've just started.
Yeah, it's always great to have something new to learn on something, because I think it keeps the mind, engaged in and different neurons that light up when you are practicing something new or doing something new as well.
I like reading also.
What kind of books?
Ancient history, the science behind mythology. I like reading that.
Any recommendations?
I see. So there are a lot of these books. If my kid reads Amar Chitra Kada, if you see those, I mean, there's so much to mythology. They're just not stories. There's always a science. There's a science behind it. So if you just see, they were right for their age. When you look at our ancestors, they said, don't do this at this particular time, or don't do that. They had food, rice that was kept overnight and had the next day morning, 6 o'clock, 6 in the evening and 6 in the morning. That's actually very rich in B12. And that we are doing now because somebody abroad had told us. They ate before sunset. And they ate again after sunrise. That is what intermittent fasting is all about. And the food that they asked you to eat at certain times, somebody delivered, they would ask them, delivered recently, they would ask them to eat food rich in ghee. Why? It's vitamin D. It will in turn help your calcium. They recommend you to eat a lot of foods rich in calcium, iron, because back then there was no calcium, there was no iron. Those were not myths exactly. And when I say mythologies, that there are some temples. So you get these random books not by special authors. So I like to go to these places which are pretty old. There's something about them, the way they built them. They were way too advanced is what I feel. So I've been to this temple in Tanjore recently. The height, the architecture. I mean, how could they take a 90-ton stone to a height of, I don't know, some 90 or 100 feet? How was it done? So there's a lot to learn from them. Like our Ravana, they say, had flying machines, which were planes. And Sushruta, who's considered the father of modern surgery, I mean, ancient surgery. I mean, he was a plastic surgeon back then. This was 2000 years back. He had instruments. He operated on people. There was no anesthesia then, but he used something to, sedate them, and he did stuff. He did the first rhinoplasty. Those things fascinate me actually. So
maybe you should write a little, take some of the Amar Chitra Kathas and then write the scientific version of that. I think that will be a big hit. So use some.
I somehow tend to find these scientific versions. I mean, there's obviously fiction, like, these Alexander's Quest, and then you have this Amish Gupta series of all the mythology you have. And then there are some random articles. I find that somehow very interesting. When I like to go see those places, there's something. And there was this place, okay, wherein I think it was somewhere in Tamil Nadu, a 3,000-old tree. Okay, there's inside this old tree, it's all dried up. They took a twig from the same tree, which was 3,000 years old, or much older. They obviously dated that, and then got a new tree out of it. Few hundreds of years ago. So they're not that dumb, or after all.
Yeah, no, I think there is a lot we can learn from.
I mean, you could just look into the details around. They were very smart. So there were places of entertainment. If you see at each level, it's different. Down, you have animals to, entertain the young kids. The mid-level for the younger generation, at the higher level for the older people. If you just observe the architecture, it's very interesting.
So I'm waiting for you to write a book after this.
I don't know if I'm there yet. Maybe
So,
I'll have to travel a lot more to do that.
In a few years, not right now, but in a few years.
Sure.
So, you mentioned that you like traveling and all that, but is there a specific career that you would have chosen if it was not a surgical oncologist?
I was interested in civils as a kid.
You can still do that, right? Or you can't?
I love it too much to leave this now.
And is there any? Sorry.
I feel really good in this field, so.
Yeah, no, I think you're this is a field that impacts so many people and families that I think it's a very noble and great field to be in. Especially now, I think people are the number of cases have also started to increase. So it is more important that we have people who can create that awareness and treat the patients that require them the most. So one last question: is there a common complaint that your friends have about you?
Probably that I don't go out that much.
Yeah, that I think, unfortunately, I think with the profession like yours, I think that becomes a challenge. So I think with that, we are coming to the end of our Gupshup. Just wanted to check if something else that I left out, if you wanted to say something to our viewers and people who are listening in.
So all that I would say is sometimes, you need to prioritize first, know what a warning signs, go to a doctor, and just don't keep trying out. Please don't Google. Google doesn't make you a doctor. We don't need to lead for, 10 years or 12 years to be where we are. Google doesn't give you the right information. I've seen people Google for, beta HCG. So that's what's asked sometimes in women who are pregnant, okay, to see their levels, especially in early pregnancy. Yeah, beta HCG. So somebody Googled and they say it could have been, I could probably have an ovarian tumor because beta HCG. I'm like, Google is not going to teach you. So that is one thing I would definitely want to tell people. Don't Google extensively. It's okay to find out a little, but Google is not going to make you a doctor overnight.
Yeah, it's always better that you can be informed, but go to a doctor to make any.
Yeah, to have a basic idea is good, but creating your own treatment chart from that,
probably not a good idea. Yeah,
not a good idea.
Yeah, I guess the same goes for ChatGPT and all the other newer versions of what you can do today.
Exactly.
Yeah. No, I think it is. This is
possible should get screened as well.
So I think, Dr. Soumya, I think today was an absolutely illuminating conversation. We learned a lot about many different things, both in terms of understanding, different ways of preventing, but also what treatment options are there, and also genetics and what kind of profiling goes into it. So thank you so much for your time. I think I learned a lot, and I hope that a lot of the people who are watching and listening into this conversation also will feel the same. So thank you once again.
Thank you so much, Anu.
Thank you.
Thank you for having me.